Part 1. The Fundamentals. Adrenaline, morphine, naloxone. The drugs that keep the body alive when everything is failing. Part 2. The cardiovascular system. Vasopressors, inotropes, antiarrhythmics. The drugs that keep the heart pumping and the blood pressure stable. Part 3 is different. This part covers the situations that require a specific antidote, a specific reversal agent, or a drug that fits a situation no other drug addresses. Patients with seizures that will not stop. Patients with overdoses that need reversal. Patients with uncontrolled bleeding. Patients with bronchospasm that is not responding to standard treatment. For each drug, we explain the mechanism, the indication, and the English vocabulary you need to describe what you are doing and why. If doses are needed, drop the comment. Part 3. Let's finish the series. Drug number 1, Diazepam. Diazepam is a long-acting benzodiazepine. You may remember from Part 2 that midazolam is the short-acting benzodiazepine. Diazepam is its older, longer-lasting counterpart. Both work by enhancing the effect of GABA, gamma-aminobutyric acid, the main inhibitory neurotransmitter in the brain. When GABA activity increases, the brain becomes less excitable, seizures slow, anxiety decreases, muscles relax. In emergency medicine, diazepam is used for, first, acute seizures and status epilepticus. Status epilepticus is a prolonged seizure lasting more than 5 minutes, or 2 or more seizures without recovery of consciousness between them. It is a neurological emergency. Second, alcohol withdrawal seizures. Patients withdrawing from alcohol can develop life-threatening seizures and delirium tremens. Diazepam is the preferred agent because its long duration covers the withdrawal period. Third, severe anxiety and acute agitation, for example in psychiatric emergencies or procedural situations. A key clinical phrase, titrate to effect. This means you do not give a fixed dose and stop. You give a small amount, wait, assess the patient, and give more if needed. This is fundamental to safe benzodiazepine prescribing. Drug number 2, Flumazenil. If diazepam and midazolam are the problem, Flumazenil is the solution. Flumazenil is a benzodiazepine antagonist. Just as naloxone reverses opioids by blocking opioid receptors, Flumazenil reverses benzodiazepines by competitively blocking GABA-A receptors. It displaces the benzodiazepine from the receptor, and within 1 to 2 minutes, sedation reverses. The main indications are, first, benzodiazepine overdose, accidental or intentional. Second, reversal of procedural sedation, when the patient has received a benzodiazepine and needs to wake up more quickly. Third, post-operative sedation from benzodiazepines given during anesthesia. Critical warning: Flumazenil's half-life is much shorter than most benzodiazepines. It lasts approximately 45 to 90 minutes. Diazepam lasts up to 100 hours. This means the patient can wake up and then become sedated again. This is called resedation. You must monitor the patient closely after giving Flumazenil. Do not leave them unattended. Second critical warning: in patients with benzodiazepine dependence, long-term users, Flumazenil can precipitate acute withdrawal seizures. This is life-threatening. Know your patient's history before giving it. A pair of words worth learning together: agonist and antagonist. An agonist activates a receptor. An antagonist blocks it. Diazepam is a GABA agonist. Flumazenil is a GABA antagonist. Morphine is an opioid agonist. Naloxone is an opioid antagonist. This pattern repeats across pharmacology. Learn it once and you understand dozens of drug pairs. Drug number 3, sodium valproate. Sodium valproate is an anticonvulsant, a drug that prevents or stops seizures. It works through multiple mechanisms. It blocks voltage-gated sodium channels, increases GABA levels in the brain, and blocks calcium channels. This makes it one of the most broadly effective anticonvulsants available. In emergency medicine, intravenous sodium valproate is used for status epilepticus, particularly when benzodiazepines alone have not controlled the seizure. This is called second-line treatment for status epilepticus. It is also widely used for long-term management of epilepsy, including generalized tonic-clonic seizures, absence seizures, and myoclonic seizures. These are terms you will encounter when taking a seizure history. One critical safety point: sodium valproate is highly teratogenic. This means it causes harm to a developing fetus. It must not be used in pregnant women or women of childbearing potential without specialist review and very careful risk-benefit discussion. In many countries, this is now a legal requirement. When documenting or handing over a patient on sodium valproate, you might say, "The patient is known epileptic on sodium valproate 1,000 milligrams twice daily. Last seizure was 3 months ago. She is compliant with her medication." Compliant means the patient is taking their medication as prescribed. Drug number 4, Levetiracetam. Say it slowly. Levetiracetam. This is worth practicing. It is one of the most mispronounced drugs in clinical medicine, even by native English speakers. Levetiracetam is a modern anticonvulsant that has largely replaced older drugs like phenytoin in many emergency protocols. Its unique mechanism: it binds to a protein called SV2A, which modulates neurotransmitter release. Unlike valproate, it does not significantly interact with most other drugs, and it is safe in pregnancy. In emergency medicine, Levetiracetam is used for status epilepticus as a second-line agent after benzodiazepines. It is also used for seizure prophylaxis in patients with brain injuries, tumors, or following neurosurgery. One of its major advantages: it can be given intravenously at a faster rate than phenytoin, with a better safety profile. Key vocabulary for seizure medicine. Tonic-clonic describes a seizure with a rigid phase followed by rhythmic jerking. Ictal means during the seizure. Post-ictal means after the seizure, the period of confusion and drowsiness that follows. These 3 terms appear constantly in emergency neurology. Drug number 5, Aminophylline. Aminophylline is a bronchodilator, a drug that opens the airways. It works by inhibiting an enzyme called phosphodiesterase, which increases a chemical called cyclic AMP inside smooth muscle cells. This causes relaxation of the bronchial smooth muscle, widening the airways. Aminophylline also stimulates the respiratory center in the brain, increasing the drive to breathe, which makes it useful in apnea of prematurity in neonates. In emergency medicine, aminophylline is used for severe acute asthma that has not responded to first-line treatment, salbutamol, ipratropium, and corticosteroids. However, aminophylline has a narrow therapeutic window. The difference between an effective dose and a toxic dose is small. Toxicity includes nausea, tachycardia, seizures, and ventricular arrhythmias. Aminophylline levels must be monitored in the blood. An important clinical question to ask before giving aminophylline: is the patient already taking theophylline at home? Theophylline is the oral form of the same drug. If the patient is already taking it, giving a loading dose of aminophylline intravenously will cause toxicity. Always check the medication history first. Drug number 6, Heparin. Heparin is an anticoagulant, a drug that prevents blood from clotting. It works by activating a natural protein called antithrombin 3, which then blocks several clotting factors. Without these clotting factors, the coagulation cascade cannot proceed and clot formation is prevented. Heparin exists in 2 main forms in clinical practice. First, unfractionated heparin, UFH, the original form given intravenously or subcutaneously with a rapid onset and short duration. Second, low molecular weight heparin, LMWH, such as enoxaparin or dalteparin. These are given subcutaneously once or twice daily with more predictable dosing and no routine monitoring required. Emergency indications include deep vein thrombosis, pulmonary embolism, acute coronary syndrome, atrial fibrillation with high clot risk, and prevention of clotting during hemodialysis and cardiac surgery. Key vocabulary: anticoagulation, is the clinical process of preventing blood clotting using drugs. When a patient is anticoagulated, they are at increased risk of bleeding. This must always be communicated clearly during clinical handover, the transfer of patient care between teams. Drug number 7, potassium chloride. In clinical shorthand, this is written as KCl, said as individual letters KCl. Potassium is an electrolyte, a mineral dissolved in the blood that carries an electrical charge. It plays a critical role in the electrical activity of the heart, nerve conduction, and muscle function. The emergency indication is hypokalemia, abnormally low potassium levels in the blood. Normal serum potassium is 3.5 to 5.0 millimoles per liter. When it falls below 3.0, the patient may develop muscle weakness, cramps, and cardiac arrhythmias. When it falls below 2.5, this is a life-threatening emergency. This drug carries one of the most important safety warnings in all of medicine. Undiluted potassium chloride, given rapidly intravenously, causes immediate cardiac arrest. It has been involved in fatal medication errors worldwide. Many hospitals store concentrated potassium chloride solutions in restricted areas and require a second nurse or pharmacist to check the preparation. Always follow your institution's local policy. Drug number 8, Tranexamic Acid, or TXA as it is known in trauma medicine. Tranexamic acid is a hemostatic agent, he-mo-sta-tic, a drug that stops bleeding. It works by blocking a process called fibrinolysis, fibrin-o-ly-sis, the natural breakdown of blood clots. Specifically, it blocks plasminogen activators, preventing the conversion of plasminogen to plasmin, the enzyme that dissolves clots. By blocking this process, TXA allows clots to remain intact and bleeding to stop. The clinical evidence for TXA is powerful. The CRASH-2 trial, one of the largest emergency medicine trials ever conducted, showed that TXA reduces mortality in trauma patients with significant bleeding, but only if given within 3 hours of injury. After 3 hours, it may actually increase mortality. The time window is critical. Indications: major trauma with significant bleeding, postpartum hemorrhage, bleeding after childbirth, upper GI bleeding, and surgical bleeding where fibrinolysis is contributing. In trauma handover, you will often hear TXA given at scene, 1 gram intravenously, approximately 45 minutes ago. The phrase "at scene" means the drug was given at the location of the injury, before the patient arrived at hospital. This is important to document because it affects when the second dose is given. Drug number 9, Promethazine. You may know it by its brand name, Phenergen, widely recognized worldwide. Promethazine is a first-generation antihistamine with significant sedative and antiemetic properties. Antiemetic, anti-e-me-tic, means it prevents or treats nausea and vomiting. It works by blocking histamine H1 receptors, reducing allergic responses, and also blocks muscarinic receptors, dopamine receptors, and has alpha-adrenergic activity. This broad receptor activity explains both its usefulness and its side effects. Emergency indications: nausea and vomiting, particularly in the emergency department, postoperatively, and during opioid treatment. Second, allergic reactions and anaphylaxis, as an adjunct after adrenaline and corticosteroids. Third, motion sickness and vertigo in acute presentations. Fourth, sedation, as a component of procedural sedation, particularly in pediatric patients. An important side effect to recognize: extrapyramidal effects. These are movement disorders caused by dopamine receptor blockade. They include dystonia, involuntary muscle contractions, and akathisia, a distressing inability to stay still. If these occur, the treatment is procyclidine or benztropine. Our final drug, or rather our final drug pair, Metoprolol and Esmolol. 2 drugs, same class, very different durations of action. Both are selective beta-1 blockers, also called cardioselective beta blockers. They block beta-1 adrenergic receptors in the heart, slowing the heart rate and reducing the force of contraction. Because they are selective for beta-1 receptors, they have less effect on beta-2 receptors in the lungs, making them safer than non-selective beta blockers in patients with mild asthma. When do you reach for these drugs in an emergency? First, rate control in atrial fibrillation, when the ventricular rate is dangerously fast. Second, acute hypertensive emergency, particularly in the context of aortic dissection, where reducing both heart rate and blood pressure is critical. Third, supraventricular tachycardia, as an alternative to adenosine in certain cases. Fourth, perioperative heart rate control, managing tachycardia during or after surgery. The key difference between the two drugs. Metoprolol has a duration of action of 3 to 8 hours, given intravenously or orally. Esmolol has a half-life of approximately 9 minutes. This makes Esmolol uniquely controllable. If the patient develops side effects, stopping the infusion rapidly resolves side effects. This is why Esmolol is preferred when precise, titratable heart rate control is needed, for example, in aortic dissection. In this situation, in English, you would say, start Esmolol infusion, target heart rate below 60, titrate up every 5 minutes, call me if systolic drops below 100. 3 parts, 30 drugs. This is the complete series. Let us close part 3 with a final review. Diazepam, long-acting benzodiazepine for seizures and alcohol withdrawal. Flumazenil, the reversal agent for benzodiazepines. Watch for resedation. Sodium valproate, a broad convulsant, highly teratogenic. Levetiracetam, modern anticonvulsant, fewer interactions, safer in pregnancy. Aminophylline, bronchodilator for severe asthma, narrow therapeutic window. Heparin, anticoagulant for DVT, PE, and acute coronary syndrome. Potassium chloride, essential electrolyte replacement, never as a rapid bolus. Tranexamic acid, haemostatic agent for major bleeding, give within 3 hours. Promethazine, antihistamine and antiemetic, watch for extrapyramidal effects. Metoprolol and Esmolol, selective beta blockers for rate control and hypertensive emergencies. If you have watched all 3 parts, you now have a solid foundation in emergency pharmacology in English. The next step is practice. Use these words in your clinical notes. Say the drug names aloud in handover. Language becomes fluent through repetition, and in medicine, fluency matters. Thank you for following this series from part 1 to the end. Subscribe for more medical English content. Drop Drug 3 in the comments to get free PDF with exercises. Follow for more Medical English Pro.